just want to be clear with everybody. UAMS want to be clear with us that they were mentioned in the last presentation as being available as part of the research assistance that might be necessary for that. They want to make sure that the task force knows that they will make their services available to any group that's selected. They're not a subcontractor, they would just be a resource, and they're more than willing to participate. So they want that clarified. And one other point that I talked with Jill about during lunch that I want to clarify with folks is there were a lot of questions about travel expense and termination of the initial work services. She just wanted to relay to me, and I think it's important to relay to you all, that she's comfortable that those who submitted understand the scope of work and the expectations, and that the amount of work that would be necessary after this final report at the end of this year is significantly less than would be anticipated before then. In her experience in doing these, there's usually a pretty good understanding, and they'll clarify that if there is any disagreement during the application process. But she wanted that. So she's had a lot of discussions with these folks, and I think they understand what they're bidding on. So, all right, next group we're going to hear from, and you all should have your paper with the name at the top is Navigant Consulting. I asked them where they're from, and they come from all over, so we're excited to have you all here. I'm going to let you introduce yourselves because we do have 5 of you here, and we're glad to have you. What we've asked in the past, and just so you guys have a feeling for the flow of this, is I think Bill should have told you about an hour to present, plus or minus. That maybe flex some, because if members of the committee have questions that they want to ask during the presentation, I'll try not to be rude, but I may interrupt you to ask or Representative Collins may, so that people can ask something that's relevant to what you're addressing at that time. After your presentation is finished, we have about 4 standard questions that we're asking of everybody that you'll have an opportunity to comment on. And then the task force members, I'm sure, will have several questions that they'll want to have some discussions with you about. So again, thank you all for coming. You all can just introduce yourselves, tell us a little bit about what your role is, and then you're obviously approved to proceed with the presentation.
Thank you very much. We're absolutely delighted to
Okay, is that green light on? Can you pull the mic down there towards you? Yeah, now pull that mic down towards you.
Great.
Thank
you again for inviting us to be here. We're very excited about the prospect of working with you on this study, and we commend you for taking the time to do this very thoughtful, detailed study. You've identified a series of very, very detailed questions that will certainly help in exploring the options that are available in the next several years. I'm going to move right on to introductions of our team. I am Catherine Starkovich. I'm with Navigant Consulting, and I'm the leader of our government healthcare practice, where we do work with both federal government and state government. I'm going to be working on this project as an advisor as needed. In my background, I have worked with just about every state Medicaid program in the country over the last 30-some years, and have worked with a number of other state agencies. And most recently, I've been working with states in their Medicaid transformation activities as they work to implement new and innovative approaches, many of which you have already undertaken here in Arkansas. Dave, do you want to go next?
Sure. I actually had the pleasure years ago of hiring Catherine when I was the CFO of the North Carolina Medicaid program, as well as several resources. So I've been working in and around this group of people for quite some time. I left as a partner with a national CPA firm where I focused just on Medicaid issues. Left there 2.5 years ago, and in all candor, put it on the work for several folks, including many that proposed on this work. I chose Navigant because of the work that Catherine and Jennifer and others have done for me over the years and quality work.
Okay, just for the benefit, again, we got folks in the back who have a hard time here. Just make sure you pull that mic up.
Yes, sir.
Thank you.
So my name is Dave Buswood, and years ago I was the CFO of North Carolina's Medicaid program. I was a partner with a national CPA firm where I focused exclusively on regulatory healthcare issues for 9 years. Left that firm about 2.5 years ago to join Navigant with Jim. And my focus is on, as I mentioned, regulatory issues, but I offer a lot of policy. I'm often called upon to help folks on the Hill, to work with folks in different legislatures, Medicaid directors, helping them with high-level policy communication with federal regulators, working with chambers of commerce, the hospital association, others, to make sure that things are really happening on a collective, collaborative manner, and that the details really come through. In fact, I would also like to echo my congratulations to you in embarking on this process. I had the pleasure of meeting with your current governor when he was running for governor, and then after he was elected. And he asked me candidly what 2 things would I suggest. And I said, you need to make sure your house is in order with regard to your federal claiming on your 64 reports, which is how you draw down federal dollars. And someone needs to take a look at the very forward-thinking program that the legislature adopted some years ago that had a lot of variables and a lot of data. It was, although well-intended, it's time to take a look back and shoot that up to make sure that the promises that were made and the assumptions that were used have come to fruition. I've worked with Jennifer Hutchins, and in fact, I've worked with Jennifer for 15 years.
Hi, I'm Jennifer Hutchins, and I'm proposed as the project director. I've been with Navigant for approximately 15 years, and in the industry for about 5 years before that. I work primarily with state Medicaid agencies on program design, implementation, support, and operations. Most recently, I've helped states with considerations for all sorts of program reforms, managed development of a very large report for the state of Georgia on reform opportunities, as well as smaller initiatives with other states, white papers and so forth, conducting a lot of state research, so it's very good with the nation.
Good afternoon. My name is Dawn Johnson. I am a principal at Sellers Dorsey. I'm in charge of national consulting for Sellers Dorsey. Sellers Dorsey, if you don't know, is a consulting firm focused on Medicaid finance, health policy, and healthcare transformation. By discipline, I am a registered nurse, so I approach everything in healthcare from the views of a clinician, whether it be from an IT perspective, whether it be from a systems perspective or program evaluation. I focus a lot on vulnerable populations, those entering into the program, those being served by the program, and those whose needs are not currently met by the program. We are pleased to work together with Navigant in this capacity.
Good afternoon, my name is Ann Reisenberger, and I'm working with Sellers Dorsey as an affiliate. My background includes over 25 years working in Medicaid, starting as an assistant attorney general and Medicaid counsel for the state of Maryland. I was there for 13 years and was intimately involved with a number of the issues I know are concerned for your state around eligibility verification, around provider compliance. I have been in consulting for over 9 years, and during that time have been counsel to, giving consulting advice to the District of Columbia. They were facing a number of, it appears to be similar issues that your state is facing. I did audits, I did evaluations, I did state surveys to help the district identify areas where they could improve their management and administration of their Medicaid program. I'm also familiar through other work with states that have recently adopted capitated managed care programs, Kansas and Louisiana for another engagement.
So I'm just going to take a minute or two more just to talk a little bit about these combined teams of Navigant and Sellers Dorsey, and then we'll move right into our proposal and our strategy moving forward to address your questions. So we put together what we think is a very senior team of individuals that can hit the ground running and really bring to you a lot of the experiences that are needed to identify some of the issues that you've identified in your RFP. If you haven't heard of Navigant, Navigant is the 4th largest healthcare consulting firm in the country. We have more than 1,500 people. We work in all kinds of industries and segments. And I think what's important for this group to consider when you're looking at the Navigant consulting team is that we bring together people with experience. At this table, we have a lot of Medicaid and insurance health plan experience and other kinds of experience, including provider experience, because it really, as we start to look at reform initiatives that are taking place now across the country, there really is a convergence of providers and payers, and the old order is no longer the case. And so as we think of innovative ways to change Medicaid and change how you're delivering services to individuals, we need to make sure that we're considering all of the various parties and how they come together to serve the public and other individuals. I noticed that one of the questions that you had as the paper kind of slid by me here was what distinguishes us from some of our competitors. And I think the way we, in addition to what I've just discussed with regards to our complete suite of services to serve both health plans, providers, state government agencies, the other thing we bring is just a really practical, hands-on solutions to clients, and we stick around and we help implement those and operate those. And so in our development of recommendations, we tend to be pragmatic, we tend to be just recommend those kinds of initiatives that can be implemented and that you can, that our clients can live with after we leave. It's not our goal to, to create programs that we have to be here to help you with for the next 10 years. We want to give you the solution, we want to give you a roadmap to implementation, and then help you understand going forward what you need to continue to monitor those programs. So I'm going to turn that over to Dawn now. She's going to talk a little bit more about Sellers Dorsey, and then we'll move into our approach.
The slide you have in front of you describes Sellers Dorsey, but what I think you should take away from Sellers Dorsey is when Sellers Dorsey has bid on a proposal, the team that's bid is the team you get. You get very high level expertise from either the health plan. We have former state Medicaid officials. We have a former CMS official. I worked and ran the CMS program that was the largest demonstration of care management for fee-for-service dual eligibles that came out of CMS. And what we like to do is make sure that our clients are served and are happy before we exit any engagement. We do a lot of financing work across the country. We're involved in a number of states with universities and payers and providers, and our name and our reputation are very important to us.
I would echo I would echo what Catherine said about what differentiates us. I think one of the things to keep in mind is the team you see here is the team you'll actually get. It's not uncommon that I see the same names over and over again in proposals from other companies, and you don't see those folks. They're in the proposal that they get. They actually work on the proposals that they are named in, and you work 8,000 hours a year. You'll see these folks, and you'll see the core members of our team. I think that's a differentiator, that we develop a rapport and a relationship with you to help derive success. We also don't bring folks through to do on-the-job training. The folks that you get are seasoned professionals. We do have interns. They are a resource to us. Of course, we bring on new folks. The people dedicated to this team truly are unique individuals. They pour their expertise. The subject matter experts that you have, I don't think it's a small issue to gloss over. We bring you folks that have run health plans, folks that have run hospitals, folks that have led the Center for Medicare and Medicaid Innovation with CMS, folks that have been CFO of Medicaid programs. I think that combined with the long-term 15-plus year relationship that Navigant's leaders have had with Sellers Dorsey brings a proven team. Our references are impeccable. Your team is also a conduit to over 1,000 professionals, whether they be psychiatrists, psychologists, economists, biostatisticians, epidemiologists. The team serves as a conduit back to Navigant as a whole. I also think that you'll see that we responded in a manner that's very pragmatic. We didn't pretend that you needed more services than were required. The folks doing this work have been doing the work for decades. We understand Arkansas. We understand the unique issues attributable to Arkansas. In fact, I was with Randy Zook from the Chamber of Commerce not long ago on a plane and spent 2 hours talking about this very matter and how it relates to the wellness of the business community and the population within the state also addressing the various idiosyncrasies and technical details that are going to be unveiled through the process that you have in hand. As we look through the team, what we tried to do was to list each of the individuals that would be serving you, and across the top you'll see a list of prior experience and specific skill sets and attributes. Again, this team that we propose is the team you're going to get. And I think that what this does is gives you a clear example, a clear illustration that everyone that we proposed brings unique qualifications to you that no one else can. There's no one else that we propose that has prior hospital CEOs, health plan CEOs, economic development professionals, statisticians, MDs. It's just a unique skill set, and we stand ready to contribute to your success, that of the governor of the United States of Arkansas. We're strategic thinkers. We're going to give you results that are actionable. We don't pretend to provide you with a compendium of literature that's of little use to you and doesn't provide a concise roadmap that's of value. In the graphic, we mentioned the term success. Success is not a universal definition in any state, or between different states, or amongst the folks in this room. We understand that success takes many forms. What we try to do is ensure that the information that you have allows you to make objective decisions that are in the best interest of your electorate in order to derive success from one of the largest budget items that you will address each and every year, and will continue to grow over time. From hospitals, advocates, other providers, the chamber, I can tell you that I got cut in Eudora, Arkansas, and I was very surprised to find out folks in Eudora, Arkansas were interested in your healthcare program, and that they understood what was going on and that they wanted to discuss it. I think that this is a far-reaching program. You guys have invested a lot of political capital. You've invested a lot of finances, the state's dollars, the federal dollars, all based on what might be very well-founded assumptions, projections, and models. But it's time to take the data and have a retrospective analysis to see if you still are on the trajectory that was promised you.
So our service strategy, others at the table have covered somewhat. I just want to reiterate that we will bring real-time knowledge from experts on national Medicaid and commercial healthcare service trends. Our team is here. We will be here. The same team as we proposed, and we have a deep understanding and experience with the state as well. Individuals that we would bring in have subject matter expertise. Many of us have worked on large-scale health reform initiatives as well as the private insurance market in the marketplace. We also bring great familiarity with CMS and federal regulations. Many of us have helped states as they work with Medicaid state technical assistance teams, considering health reform opportunities and the required federal authorities for that. We consult with them throughout that process and help to facilitate those meetings. We also have a Center for Healthcare Research and Policy Analysis. They're focusing on current trends within the market, and we will tap them as needed to support initiatives here and understanding of those. And as Kathy mentioned earlier, we're partners, not just advisors. We have long-term engagements with states where we aren't just going in and making recommendations for solutions, but we're there helping to implement those. And so we're aware of the challenges faced as well as the successes, and bring those to any evaluation that we do.
As I mentioned before, Arkansas has been at the forefront of designing a unique and innovative payment model. Arkansas provides funds as premium assistance to purchase coverage in the marketplace and to the QHPs, the qualified health plans, for newly eligible members, including parents from 17 to 138% of the poverty level. The Community First Choice option I would call your attention to on the slide. That was a big issue a couple of years back, and I know you're debating it now. I would tell you that the Community First Choice Option Program, the way it was presented to you, used a bifurcated payment model, which allows the Medicaid program to pay providers under the Community First Choice Option waiver a different rate than Medicaid pays those providers for folks who are not in the waiver. CMS hasn't allowed that anywhere else. The information that you were given was based upon a premise of a bifurcated payment methodology that I'm not aware CMS has ever approved. I'm not saying that the information is wrong, but I'm saying that you guys are doing a lot of very creative things simultaneously. And again, you're a national leader. I'm proud when I go to places and people talk about what New Mexico is doing with telemedicine. How states like Wyoming, North Dakota, New Mexico, Alabama are dealing with healthcare access for the medically underserved counties. You've got a lot of medically underserved counties. That's physical health. When you start looking at the access for the developmentally disabled population and the mental health and behavioral health services that are required, you're far more underserved in many counties than you realize. Telemedicine is a big step forward. Your program providing access to individuals is a huge step forward. You're providing them with insurance. It's also incumbent to make sure that they have access to care, not just an insurance card. As you know, Medicaid expansion has not been universal. We've seen, in my humble opinion, the administration endeavor to be coercive, punitive to states that have not expanded. As an expansion state, I think it affords you a certain latitude with the federal government that is warranted. I think you took a big step forward and took a chance on something that could be hugely beneficial. But it's important to also look at what other states have done and see if there are best practices out there that have been adopted since the time that your decision was made. If you look across these different states, none of them got the work requirement that everybody was seeking. I was surprised. I thought Indiana might be able to get it. We've worked with all of these states. We know that in many of these states, the results are in yet. By being an early adopter and an innovator, you have a chance to look at your program, to gather the retrospective data, run it through the models that were created to justify the program, and help be a guiding light for states across the nation.
Before you leave that slide, can I ask one question?
Yes, please.
You said you've been involved in all of these states that are on this chart here.
Yes, not involved in creating necessarily their new waiver programs, but we've done work in each of these states.
So you've got Iowa, Indiana, Michigan, Pennsylvania, New Hampshire. In general, which of those has the lowest per month per person cost to administer the expansion program?
I can get you that information. I can tell you that across the board, Iowa's running a pretty great program. Iowa's doing a neat job. They're having trouble with New Hampshire. The costs are a bit more than what they had expected. Pennsylvania is kind of a non-issue, and it was adopted under a prior governor. The new governor came in and was going to start from scratch again, so we really don't know the impact. Michigan is in the middle of making a lot of changes as well, so the numbers aren't in on the expansion. Indiana, I think, will be, once it's implemented. The problem is they had to implement so quickly once CMS made the decision, and I'm not sure their plans were all ready to take those individuals. But I think down the road of these states, I think you'll see Indiana faring the best. It's also important to remember when you look at states like Iowa, it's such a homogeneous population, and their benefit package is so much different. People often ask me, for instance, why are the rates so much higher in my states for nursing homes, or why are they higher for something else? Every state has different requirements and different benefits, even as far as nursing goes. The number of attendants, the number of days, the number of times the hair has to be washed, the number of times they have to be seen. Do they keep the beds open when people go to the hospital or transferred out? So I don't mean to try and school you, but if you've seen one Medicaid program, you've seen one Medicaid program.
I'd also add that I was in the process of procuring for managed care for 10 oldies, and so that program would change. Again, I believe the proposals are due with the end of next week. So.
The common risk associated with implementing innovative models, anytime you're innovative, you're going out of the realm. More risk is hopefully more return. In the case of Arkansas, you develop models and formulas into uncharted territories. You used the best data that was available, but your data was not contemporaneous, complete, or verified. You also anticipated member behavior. You assumed that the newly insured individuals would behave like the individuals that had insurance before. I can tell you that individuals that are newly insured are not behaving in a manner commensurate with the prior insured population. One of the biggest areas that's apparent is that the folks that are newly insured, when they were uninsured, would have been seen under EMTALA guidelines. Hospitals would have been required to stabilize and treat them and then to discharge them. Those individuals now have a much broader set of services that they're receiving. However, nationally, most of the folks that got onto the exchanges chose bronze plans. They chose the lowest cost plan, which is the highest deductible, highest copay. Now those individuals are utilizing hospitals and they're not paying their copays and they're not paying their deductibles. So what's happened across the hospital industry is that in many cases, you've taken away uncompensated care and you've replaced it with bad debt. And the bad debt that they're incurring is not allowable for calculations to receive the disproportionate share of hospital dollars. So as we go through and look, it'll be important to note where the assumptions were made about how people would behave, what the financial impact would be, what the wellness issues are, and that the people are truly more healthy and are getting the care that they need. The other issue is that there was oftentimes a lot of demand for services, and now you have folks that were eligible for services for the first time, and they're coming in and you're finding out that they have a lifelong history of disease that was undiagnosed and untreated. So they're consuming services differently, and it's different by state, it's different by region within states, and I think that you'll see great differences even by counties within regions in the state of Arkansas. The questions we would hope to answer in short order is the uninsured rate dropping as it was expected to drop? What is the acuity level of a newly insured population? How are new beneficiaries consuming services? Are the new beneficiaries consuming services in a manner commensurate with Medicaid individuals, with uninsured individuals, or with previously insured individuals? What is the current financial impact of the program? And by that I mean the federal dollars that are coming into the system. What does each federal dollar contribute as it multiplies and is repeatedly spent throughout your state? How does it impact your ability to budget and forecast for the next year? How do current trends indicate future impact and return on investment? Again, it's time to true up the numbers, see how things really look based upon actual outcomes and data, and trend that going forward to make sure that you have the information you need to make the important decisions at hand. A comprehensive assessment for informed decision making. What areas warrant immediate changes to accommodate actual versus anticipated? Where are we going to find issues for which you have to plug a hole quickly? Do the results and anticipated trajectories parallel the objectives of the current legislature and governor? Realizing, of course, that a different body and a different governor adopted this program.
what has changed, what are the demands, what information does this body, the new legislature and the new governor, require in order to endorse the program and to make it the best program it can be going forward. How does Arkansas's program compare to other innovative or traditional programs? Being as we're working in so many states, we have the ability to quickly identify trends and to offer comparative analysis. And how might Arkansas make pragmatic adjustments to benefits to address the internal and external lessons learned? Not only what you're learning in Arkansas, but what other states are learning, and what's happening nationally with this newly insured group of individuals, and what's happening with Medicaid programs across the nation.
Are there any questions before we move into our approach? We would initiate the project by having a kickoff meeting with key individuals from the state, including the contract manager, as well as other assigned parties. We would want to identify any information you might have that we would want to review as part of the study. We would also want to get input about our proposed approach, if there are any pieces of that that you all would like to discuss. From that, we would adjust our implementation plan. We want to understand work streams that are currently underway. We proposed a high-level work plan, but we would really build that out so that we could monitor our progress, indicate responsible parties, and so forth. And then with that, we would have ongoing status reports to the state. We would recommend having weekly status meetings with the contract manager just to report our progress, given the time frames are pretty tight for the study. And also, where we're recognizing challenges and so forth, the data sometimes is a little bit challenging to get quickly. And so we would want to talk through that and recommend our solutions for any of those.
I think it's also important to mention that we expect this to be an iterative process, and we priced it as such. When you look at a risk analysis and we start crunching through the numbers, where we find no problems, there may not be a need to dig. We would rather save those resources to use them in the most efficacious manner possible for the state. We have the judgment and the expertise and history to help you work through that process so that we're not offering unnecessary tests, unnecessary issues, unnecessary data extracts. We'll give you the information in the most expedient, concise, and cost-effective manner.
Also, at the beginning of the project, we would want to just talk about the data request process, identify who the points of contact for that are. Again, given it's an iterative process, we would assume we would be in contact with them regularly to get the data as quickly as we can and in the format required. We would talk about our deliverable submissions. We tend to, particularly with studies, we want to have a really good outline of those provided as drafts for input, making sure we're getting the consistent feedback that we need to, so that there are no surprises at the end when we submit our report.